Okay, just some questions that I've had since I ran the full mouth rehab course in Sydney. I'll go through some of those. Why don't I use an intraoral camera? It's a fisheye lens. That's how you can get such a small lens in there, so it's a very wide angle lens. At that closeness to the tooth, it distorts the tooth, so the tooth looks a weird shape. The lighting is bad, you don't have very good flash. The pictures are not crisp, so they're just not good photos. And I use a proper camera because I want really good photos, and I want full arch photos that I can zoom in on the tooth, and then the patient can see their face, they can see their smile, they can see the retracted pictures, they can see the full arch pictures, so they know it's their tooth. If you just show them a single image of a tooth taken out of context, the patient can't really relate it to their mouth. They just think, oh, show me any old picture of a tooth. How do you manage a worn dentition in order to restore function? So decide where you want the teeth. And by the decision of where you want teeth, I mean where do you want the incisal edge, where do you want the gingival margin, where do you want the midline, how labial, how lingual. Okay, you decide that first. Then you work out, how do I make that happen? Can I make it happen, and how do I make it happen? Most of the time you can make it happen, and then you just got to work out how. So do you make the teeth thicker, do you make them thinner, do you make them longer, do you push them up, push them down, do you bring the gingiva up or down? All these decisions are just technique ones, and most dentists know the techniques to do this, they're just sometimes afraid to think about it. So you know that if you want your teeth longer, that you either add to the incisal edge, or you do orthodontics to pull them down, or you do a segmental osteotomy and cut the whole jaw off and move it down. So it's not complex. What the problem is that you have fear inside you. So when you're trying to decide which one of these options, you go, oh, I know that we could do ortho, but I don't want to think about it because it's too scary. Or I know that we could do segmental osteotomy, but I don't want to think about it because it's too scary. So it's a mental blockage that's stopping you from knowing that if you need to bring the teeth down, you bring them down. Decide where you want the teeth and then work out how to get them there. If you can't get them there, then tell the patient they can't have nice teeth. It's just impossible. How to best discuss risks and consent with patients. Now, you have to be genuine in how you discuss risks. So the idea of discussing risks is so that the patient can say no if they want to. Okay, so this is where many people get confused. I think consent is you talk the patient into a procedure and then you cover your bum so that you don't get sued by getting the patient to understand all the risks after you've solved them. So the consent process is actually you tell the patient all the risks and allow the patient to decide whether they still want to do the procedure or not. Now, if the patient says no, you should be happy, because when a patient doesn't go ahead with a procedure, and they stop going ahead with the procedures beforehand, then that's a good time to find out. It's good to find out that the patient doesn't want to go ahead with it before you do it, than when you get halfway through and then you find out they didn't really want to do it. So you will get this, you'll get patients who agree to do the treatment because you talk them into it. But then halfway through the treatment, they're kind of going, I wish I'd never done this. Okay, and then you'll wish that you hadn't done it either. It's difficult to discuss risks when you don't have experience because you actually don't know what can go wrong. So when you start out with implants, you think that implants are magical and nothing goes wrong. Later on you realise that lots of things go wrong, and so you're generally talking about the things you've seen go wrong. It's very difficult to talk about the things you've seen go wrong if you haven't seen them go wrong. This is why dentists tend to get better after they've made a whole lot of mistakes, because they don't want to make them again, whereas dentists who haven't made the mistakes don't know to avoid them. So it's very difficult to teach how to avoid mistakes because you haven't seen them and you haven't felt them. With consent, you need to have three parts. You need to have the discussion about the treatment. Then you need to have financial consent. That means you've told them all the costs and they've signed. And then you should have something written as well. Now, the written stuff doesn't necessarily mean that it covers you any better. It's just that some people think differently and they need to go home and read it. So we do that. We discuss the risks. We give them the risks in writing and we get them to sign financial consent. So they've got the verbal consent, written consent, and that. It's very important. Your verbal consent is probably the most important. You need to record it. That's why when I'm doing it, I have a dental assistant typing everything I say, so that the entire conversation that maybe goes for an hour is recorded. The question is, I have some questions about the Dale principle. I know its indications, but I have some difficulties grasping the build-up stage. What's your typical approach when you decide to dull a patient. My view is that dull is good in some circumstances, but a lot of times it's a bit overused. Now the reason it's overused is because dull is an uncontrolled technique. In its original form it wasn't uncontrolled, but the way it is done now it is uncontrolled. So with the dull technique, it's where the patient has worn front teeth but not back teeth. You build up the front teeth and you allow the back teeth to come together. Now the back teeth either come together for 3 or 4 reasons. One is when you build up the front teeth, because they can't touch, you've effectively made the patient a fixed anterior segmental device, which is a type of device you make for treatment of temporomandibular dysfunction. So it's like an NTI or an anterior midpoint stop appliance or a dual arch anterior stop appliance. All of these are segmental appliances. They're a bite guard that's worn only on the front teeth so your back teeth don't touch. Because your back teeth don't touch, you can't clench and you don't have all the interferences from the back teeth, so it's basically the easiest bite guard to make. These type of bite guards relax the lateral pterygoids and the other muscles for mastication faster than any other type. And so when you do build up someone's front teeth, you'd create a fixed segmental device. You know, they wear it 24/7. So firstly, a lot of the closure of the back teeth come together is them moving from maximum intercuspal position, MIP, to centric relation. So the jaw in the most anterior and superior position against the eminence of the skull. So that's the single biggest, and that's the quick part. Okay, the teeth come together really quickly because you deprogram their muscles. The second part is that you get over-eruption. Now people often mistake over-eruption when they do devices, but over-eruption can occur in this case because their back teeth are not touching. So the back teeth will tend to want to come together. You also can get some intrusion of the anteriors. The intrusion is much more difficult than eruption, so that's luckily less. But then you can get things like the lower anteriors retroclining and the upper anteriors proclining. So that's the part where we don't really know what happens. It is possible, and I have seen it, for the back teeth not to come together after 2 years. I've seen it where the front teeth have splayed out. I've seen get fremitus, so the front teeth become wobbly. So the dull technique, I think some of the complications with it tend to be a bit underreported because it's minimally invasive. Now, minimally invasive is fine if it works, but I don't think we should give something I don't think it's fine to say, well, it didn't work, but it was minimally invasive. Okay, I think that didn't work for as long might be okay, but it just didn't work because it was minimally invasive is not an excuse. So my typical approach to a dull when I'm doing one is I actually build up the teeth to where they look good, so where they look like teeth, and then I let the back teeth come together. Always warn the patient that might not happen, so have a plan for if the back teeth don't come together. What is your normal burrs that you use for restoration? Okay, I have a burr block. It has a 1.8mm round-ended cylinder that's coarse. It has a 1.4mm round-ended cylinder that's coarse. There's a 1.2. Then I have the same burrs in fine. So there's 1.8, 1.4, 1.2 round-ended cylinders in coarse and in fine. Then I have a football diamond that's fine, that's for adjusting ceramic. I have a tungsten carbide flame burr, which is a finishing burr, that's for finishing margins. I have a super fine diamond flame burr, which is for like cutting embrasures in teeth. And I have a very skinny coarse burr, which is for, I don't know, where you're trying to start a crown prep interproximally but you don't want to go through with a big burr. The last thing I have is, which I don't always have in the same burr block, is the safe-ended burrs used for doing vertical preps, so the bat burrs. So There's a long one and a short one that are coarse diamond. They're only about a 1.2mm diameter, and then there's a fine diamond, and they've got the little safe-ended bit. What are the normal polishing cups we use? There is a slide I've put in my slideshows which has the normal polishing protocol with step-by-step on it. Okay, here's the interesting question. It says, it's not uncommon these days to get conflicting views or opinions on many aspects of dentistry, either how to approach certain clinical situations or best materials. This can lead to confusion and this nagging doubt in the back of my mind. What's the best way to wade through all this information, and is it possible to know what's right? Okay, there's no such thing as what's right. Okay, it's like saying which bonding agent is the best. Well, there's no such thing. All bonding agents work, some work, a lot of the good ones work basically the same. A lot of the bad ones are terrible, but if you get 4 or 5 of the really good ones, you can't really say that one's better than the other. One will be better for one clinician because they've used it for 10 years, so a material you've used for 10 years will work better than one you've only used for 1 month. The best way to wade through it is to listen to quite a few different opinions and then realise that you have to make your own opinion. The best example might be occlusion. Like, occlusion's all very much opinion based, and this one says that's right, this one says that's right. And these people say this one's right, and if you do it any other way, you're wrong. Okay, but what I found best was to actually go and listen to quite a few of them, and then you have this, okay, a lot of their ideas are the same. So most people's ideas are actually, they only argue about the little minor differences, and most of what they say is exactly the same. So most people are saying the important stuff is exactly the same. So with the occlusion, everyone says all your teeth should hit at the same time. Everyone says you should wear a bite guard, and everyone says that don't have delicate bits that will break off hitting each other. So that's like the core part of occlusion. They're all the same. Doesn't matter which institute you go to, neuromuscular, Dawson, Pankey, whoever, they all say that bit. They then start to argue about the finer details which are harder to prove whether they're any different. So if you go to all these different people and listen, then you can kind of work out for yourself, okay, this bit's important because they all say it, and that bit's maybe not so important because they all say that each other are wrong. However, you will find this institute will teach this little technique, and for this patient it will work really well, and this one will teach this technique, and for that patient it will work really well. So when you have all these conflicts, just think of it as a big, like a buffet of information. You've got, you've got your salads, and you've got your roasts, and you've got your pastas and all this. You have all these different things, and they all go, oh, one person's saying, well, pasta's the best, and the other one's going, no, I'm on a paleo diet and I only eat meat. And so, but the truth is, if you have all of those, you can choose whatever's right for the circumstances. So you can go, this patient needs that, okay, and you can take that bit of information from that speaker or that lecturer. Okay, and this one needs that, okay, and I use the same technique. So I use many different techniques of doing a matrix, I use many different techniques of doing crowns, I do different ways of doing impressions, and I've learned all of them from different people, but then when I come to an individual patient, I might try the normal one, it doesn't work, so then I try a different one. So don't think of finding a right way. Have confidence in yourself, okay? You have to have confidence that you have your own opinion. You have to have confidence that you believe what you're doing is as good as you can, and you understand that all these people around you are going to be chattering away, telling you their opinion, and at some point you have to go, okay, I understand they've all got their own opinions, everyone has one, but I'm going to stick with my own. So at some point you have to formulate your own idea and you have to stick with it. And that means ignoring all the chatter. So one of the most important things in dentistry is to learn to ignore all the chatter that's going on around you. So whatever you do, in about 5 years you'll probably find out it was wrong. So just get rid of the idea that there's a right way. There's ways that work for a whole bunch of different procedures and for a whole bunch of different people, and you'll have to choose ones that work for you, and you'll have to have backup procedures for difficult customers. So I think that listen to many different opinions, formulate your own, have confidence in it, Listen to the chatter, but don't let it affect you. So listen to what people are saying, but don't just let it slide off you like water off a duck's back. And if you hear something amazing, then you really want to think about changing your own opinion, well, change. Okay, that's the best advice I can give this. But don't think that there's a right way. There's not one way that's right and everything else is wrong in dentistry. There's lots of ways that are right. They all work. And they work depending on how skilled you are and how much experience and what your patients are like. And it's your job to try and match the right procedure, the right idea with the right patient.